Our final session is going to be the Thieves Market, and it's being hosted again this year by Dr. Alan Brown. Alan is Clinical Associate Professor of Medicine at Medical University of South Carolina. He received his bachelor's degree at Clemson, his medical degree at MUSC. He was an intern there and then a resident at Dwight Eisenhower Army Medical Center. He has fellowship then at back at South Carolina. Then he was a major in the Medical Corps. He's been one of the best doctors in America, Faculty Excellence Award from the College of Medicine of South Carolina, and recipient of the Army Achievement Medal, Army Commendation Medal, and an Army Service Ribbon. He's published numerous articles, and he ran the Thieves Market last year to great success, and we invited him back, and I'd like to present Alan Brown.
Thank you all for coming, for having me back. We had a great time with this last year, and so I want to thank everyone who submitted cases. Format will be very lively, be very open, just like it was last year. I've asked all of the presenters to present the case in a stumper style. There's some break points where I want to have some audience participation. Feel free to yell out anything you'd like. You can either be a hero or you can enjoy the anonymity of being in a large crowd, one of the two. So with that, I'll turn it over.
Thank you, Dr. Brown. Good evening, everyone. Welcome to Thieves Market Mall. I'm Naveed. I'm a third-year resident in SUNY Upstate Medical University at Syracuse, and I'm presenting a Fiddly case of rash. The chief complaint of my patient was sores on my skin. HPI. So my patient is a 44-year-old Caucasian woman who presented with 1 week history of worsening rash. It initially started like a sunburn. That was the initial complaint. Started on her left arm and over 2 days progressed rapidly to right arm, back, breast, and thighs with blistering and ulceration. So it started like initially reddish color, pinkish reddish, turned into purplish color, and later on it appeared some blistering and ulceration. She went to Virginia Beach 3 weeks ago and did camping in Adirondacks 1 week ago. She did have mosquito bites, but no tick bites. She reported fatigue, but no fever, chills, dyspnea, chest pain, joint swelling, blue digits, dry mouth, or dry eyes. There was no previous history of similar rash and no sick contacts. She was treated for scabies 1 month ago. With that, I'll invite some differential diagnosis of Bullous rash. That's true. Photosensitivity, absolutely. Absolutely, so infectious causes, rubella. Okay, very good. So let's I'm sorry? Is she a smoker? No. Oh, I'm sorry, she is a smoker. Yeah, that's true. Absolutely. So let's review brief differential diagnosis. So infectious causes, some of them are not very common, but you see bullous rash with these: cellulitis, fungal infections, hand, foot, mouth disease, herpes gestationalis, herpes simplex, herpes zoster, varicella, staphylococcal scalded skin, streptococcal toxic shock, insect bite, scabies, and impetigo. Immune-mediated causes: bullous pemphigoid, toxic epidermal necrolysis, Stevens-Johnson's, pemphigus, SLE, and vasculitis. Inherited causes could include congenital syphilis, porphyria cutanea tarda, eczema, and contact dermatitis. So with this very brief history so far, what do you think would be the most likely cause in this case? Immunologic, hereditary, infectious, or some other? Or you could say it's not enough data so far.
We've got a vote for infection. Another vote for infection.
It's a rheumatology conference. I'll say immunology.
That was smart. That's a Thieves Market, so you stole it. Okay, so past medical history: cyclic neutropenia, diagnosed 2 years ago, by bone marrow biopsy and followed by a designated cancer center. She had a Neupogen injection 2 weeks ago for neutropenia. Other history is osteoarthritis, chronic sinusitis, asthma, depression, and scabies. Past surgical history is cholecystectomy 5 years ago, tubal ligation 3 years ago, and bilateral sinus irrigation 2 years ago. Allergies, iodinated contrast media, codeine, medications are citalopram, Xanax, albuterol, calcium, and Nasonex. She's unemployed. She lives with her fiance in Corning, New York. She smokes half pack a day for 25 years. She drinks 5 to 6 beers once or twice a month. She uses marijuana and cocaine intermittently, and last cocaine use was 1 week ago. She has 2 grown children, healthy. Father has coronary artery disease. Brothers has throat cancer and asthma. 6 of her siblings have no major medical issues. No known hematological disorder, malignancy, or autoimmune disease in the family except the throat cancer in the brother. Don't be confused, she's still a woman. So on general exam, mild distress from pain, weight is 65 kg, normal vital signs. Head and neck shows conjunctiva were clear, pupils reactive, no lymphadenopathy, no thyromegaly, moist mucous membranes, and JVP was normal. Lungs clear to auscultation. Heart was regular, no murmurs. Abdomen was soft and non-tender. No organomegaly. Extremities had no sign of cis-clubbing or edema. Neural exam was normal. Skin exam showed tender, flat, and centrally necrotic areas with irregular, discrete borders surrounding erythema and bullous areas. So you see the left arm here in the breast, and these were the areas which were affected. So lab values. Any questions before we go on to lab values? She's been doing it for years.
The question was how long had she been using cocaine, and was there a relationship to this before?
Mm-hmm.
Okay.
But she's been doing cocaine for many years, but Rash is the first time. Mm-hmm. No, she was referred to us after a week from another hospital. So at that time, most of our lab tests had already been done. So basic metabolic panel was pretty much normal. A complete blood count showed WBC count of 1.6 with neutropenia. Hepatic function panel was normal. Coagulation profile showed slightly elevated PTT. Urinalysis was normal. Creatine kinase was normal. CRP was elevated, but ESR was normal. HIV negative. Hep C antibody positive. And urine tox showed cocaine, marijuana, and benzodiazepines. ANA-RF normal. Peripheral nuclear pattern, dsDNA, Jo1, centromere histone, SSA, SSB, all normal. C3 normal, low complement C4, cryoglobulins negative, anticardiolipin IgM positive, beta-2 glycoproteins negative, Russell Vipervenum normal, hex phase was elevated, and there was atypical p-ANCA positive with a high titer directed against serine proteinase 3, but not myeloperoxidase. I hear a lot of whispering already.
That's a question.
Does she have any nasal problems?
No. She has a history of chronic sinusitis, but there was no acute issues. She had a sinus irrigation surgeries done before.
How was she doing the cocaine?
She used to mostly snort it, but she also mentioned that 1 week ago someone tampered her drink with cocaine. I'm sorry? No.
Repeat the question for me.
So she was asking, did they do H&E for elastase antibodies again? But no, we didn't do that. I'm sorry?